This program is brought to you by Emory University.
Good afternoon, everyone. Hopefully you can hear me. I know you can in this room, but hopefully over there as well in Zoom land. It's really nice to see you all. It's our inaugural meeting in this new building, in this new place, in a new time. So I'm impressed that we have, I don't know, almost 50 people. So this is great. And this is our new time, twice a month throughout the next year. And we look forward to seeing you all here. Also, I want to invite everyone to come in person if you can. You have a choice of doing it through Zoom, but I just want to tell the ECCRI fellows that you are mandated to come in person. So it's a great privilege to invite today's speaker, Dr. Peter Wilson, which most of you who are here know very well. So it doesn't need any introduction, but just to tell you a few things about Peter. He's been here since 2016, professor of medicine in Division of Cardiology. He's also trained as an endocrinologist. His appointment is also at the VA. He's also part of the Rollins School of Public Health, where he's a professor in global health and epidemiology. The way I always introduce him, and I don't want to take too long doing this because there's no justice you can do, but that he invented the Framingham risk score, which is what we all live by in cardiology, and that's how we diagnose and risk stratify people for cardiovascular disease. So that's his contribution, one of the few, but one of the major contributions, but only accounts for one of the few that he has done. He's been working in this field for, I don't know, more than 30 years. And the other fact that I want to let you know is that he's the most cited individual scientist at Emory. So with that said, he has changed completely what he does. He's now become an expert in big data and genetics, which is what he's going to talk about today.
You know, this is a special opportunity. So I set up camp in one of the, what can I say, glass corridors in this building. This is a magnificent building. I do not have an office here, so I get to sit outside and watch people walk by and carry on conversations. And it's a big change from where we last had our face-to-face. And I guess some of the people in this room will never see that. It was all very tight and cramped. Some of you know it. You're familiar with it. But I want to give you a flavor of what I am now doing. And if you're going to be in population research, and I've been doing it really since I finished my medical residency in 1978. So it's a long time, is get prepared to reinvent yourself every 5 to 10 years. And Arshad, what Arshad was doing when I arrived is not what he's doing now either. It keeps evolving. So don't get complacent. It keeps changing. And I'll give you a feel for that as we go forward. Okay. If I just hit forward, does that do it? Or I have to hit the mouse? I try to, there, that'll do it. So this is largely supported by 2 grants, and our grants are in collaboration with Boston University and Harvard School of Public Health and School of Medicine and the VA in Boston, Massachusetts, as well as the Atlanta VA. Okay. You're going to get some elements of these different issues: historical perspective, risk factors, outcomes, analyses. And then the last several slides will be genetics and traditional risk scoring for populations. Now, this slide is, this is the modern way to think about cardiovascular risk. And if you interface with our colleagues in the School of Public Health, they will remind us when we started out, we had very few boxes here. We would start with just an outpatient assessment, as you see there on the row of boxes. And those are your traditional risk factors. And then we would go to clinical disease and death. That was it. And that was pretty much everything until about 10 to 15 years ago. And now we have an overlay, we have genes, and genes can play a role at almost any one of those stepping stones as you move from left to right, with the individual without any disease. Then they can have subclinical disease, and then they can have all new nuances, so to speak, of different manifestations. And some of these things, of course, didn't even exist when I started out. Cardiac echo came in relatively quickly in population studies. ECG diagnoses were always there. But then there are other things like the imaging. We're just starting to tackle the imaging beyond echo. You know, to give you an idea of coronary artery calcification, we do not have that yet, for instance, in the VA. And it's an expensive test, so it would necessarily be done not on a random basis. So you want population science that gets close to random, or it's done on almost everybody. So a lipid profile, chem profile, blood pressure, those are done generally as part of care. So you do not have a selection bias. And that's important, because if you start measuring, well, let's investigate everybody who had a cardiac catheterization and then see if they go on and how they survive, et cetera. Well, you already have a biased group because they started out with a cardiac catheterization. So it only applies perhaps to those who had a cath. Now, here's the first challenge in big data. So as you go across there, and the sort of orange color is VA data, but then above it, as you can see in a lighter color, is non-VA data. This is always a challenge. And we have people in this room who are always trying to get non-Emory data, for instance, for deaths, the death adjudication, et cetera, and for myocardial infarction that occurred outside of your realm of usual tracking. This is a tremendous challenge, a real challenge. And so if a person dies outside the institution, you would like to have the National Death Index. So I'll intersperse some of these things as we go along. So we requested the National Death Index about 7 years ago. And some of you are going to roll your eyes. Well, Dr. Wilson, you've got 22 million veterans. How can you possibly get that? Well, we just requested and asked it for no charge interagency agreement. It took us 2 years, and we got it at no cost. It's incredible, no cost. NDI, we get all elements. We get, I think the numbers up to around 15 causes of death, primary cause of death, no cost. Doesn't charge against my grant. What about CMS, Medicare, Medicaid data? Same thing, different government agency. We got that for everything from 2002 onward, no cost. We said our first project, we only wanted it for 4 million individuals. And they said, really, you've got 22 million and you keep adding people and people drop out. Actually, it's just easier. We give you everything. So we have it for 22 million veterans. It's just everybody. And we have to do the programming to sort out for each individual project. And it gets updated. Each of those databases gets updated approximately every 6 months to a year. And if we don't list their resources and collaboration on a grant, our hands get slapped. And we're reminded, don't do that again. We have an interagency agreement and you're supposed to recognize this collaboration going forward, okay? So we create artificial cohorts. I'm gonna give you an example of this. This was how do you do something? For instance, people joined the Million Veterans Program, which is now getting very close to 1 million veterans. We have over 950,000. We started a little more than 10 years ago. But you want to attach to that group a outpatient visit. We don't want inpatient visits. We don't want somebody who was recently in the hospital for pneumonia and then grab his blood pressure and his risk factors. So we want an outpatient visit. And we wrote a methods paper about that. And it creates an artificial baseline, an artificial cohort that's anchored, so to speak, on that outpatient visit. So you say, well, okay, so Mr. Jones, let's say he gets into MVP tomorrow. We're still recruiting. And what data? Well, I'd like to go back the most recent outpatient visit he had in the VA, seeing a primary care physician, and he didn't get admitted to the hospital. And also, he's not recently discharged from the hospital. So it's sort of like, hey, that would be close to a regular see the doctor type of visit. And we did that when a lot of programming went into that. And I'll show you, this is the type of data you get. So should you work backward to get the risk factors, or should you work forward to get the risk factors? So let's say I got Mr. Jones comes in, he's in MVP enrollment today, but he hadn't been in the VA for, let's say over a year, but then he's going to have a clinic visit next week. Oh, that's not too bad. But that's after the enrollment, but it's not too far after the enrollment. So what we try to do is, in these V plots, and it was convenient because the first author is a early career scientist, now 10 years out because he's no longer early career. So the V plots are Jason Vossi, and I say we can say they're V for two names named after Jason, and as well because they shape like Vs. And the further you go back and the further you go forward, you eventually get all the data. So that's what the 100% means. I get all of the usual risk factors, and I could go backward. But then if I go forward, if I have to go into the future, I'm going to miss some follow-up. If he's going to develop, the patient's going to develop a heart disease, a heart attack or a coronary death or a stroke or something. So you prefer to go backward. We tested both ways though. So, but you don't always have to go back if you don't have anything to go back to. Do you want me to go back 2 years? Oh, that's not so good. I'd rather go forward a week or two, miss a week of follow-up, but then I have lots of follow-up after that. So these sorts of concepts. And then we started out, we were comparing New England and the Southeast. So these are different regions for the VA servicing system. And as you can see, the people in the Southeast use the VA more, and they're more likely to get the data quicker. So because they have more visits, and it's partly a black-white difference because the black participants in the VA just use the VA a lot. That's their primary source, whereas a little bit less for the white participants. Next thing. And then some of you are working on this, I know, for different projects. How do you decide somebody has an event? So, for instance, you can read through the charts. If you're lucky, you have an ECCRI chart. In the VA, we have electronic charts. We have pretty much the same chart everywhere in the United States, which is incredible when you think about it. Here we are in our own ECCRI system, and we're down to 2 or 3 systems, but it's still a nuisance, isn't it? To sort of say what, and then each one doesn't really talk to the other, but we can program these things in the VA, and we can also develop training programs so that the computer can learn how to make a probability of a diagnosis. So I'm not showing you a lot of data yet. I'm just showing you how you do big data in a population, because these are challenges that the world had never really thought about. So, all right. So you think the person had a heart attack at another institution, a non-VA institution, and then the next note for VA follow-up outpatient visit says he had a heart attack 3 months ago. The next note said he had a heart attack. And then you say, oh, well, he's 45 years old. Can I get that? No, I don't have any easy way to get that because I'd have to request the records from that hospital, right? That's the only way to get that. But he comes to the VA and I have multiple doctors writing that he had a heart attack. I might have an ECG that shows a Q wave that it didn't used to have. I may have a cardiologist. The cardiology attending says definite heart attack, 2 months ago, and was on life support, et cetera, got an emergency cath, all these things. That increases my chance. So I can use all of that information and I can give him what I think is a probability he had a heart attack. So like an acute coronary syndrome, and then he gets cath, and then he gets an intervention. Well, that's a 90%er versus, well, he goes and somebody writes CAD in the discharge summary. Gee, did he really have a heart attack? I don't know. The coronary artery disease is a really bad ICD code, just so you know. And I've read a lot of these charts. So what we do is we'll get two readers to read the charts. They make their notes, and then we have a third person. For coronary disease would be a cardiologist, adjudicate. For stroke would be a neurologist, adjudicate. And then we no longer say the person had a heart attack. We say he had a 90% probability of a heart attack. So we are now we're moving beyond 0-1 variables. We're moving into probabilistic variables. That's the next generation. All right. That's called I2B2 techniques. And that's essentially, yes, artificial intelligence. This is how you do it. And so you have two readers, then you give all that information to the computer expert and to your I2B2 informatics person. And they read, for instance, for stroke, they read 85,000 charts, actually to determine, they read all of the charts, which was millions of charts, but we determined we had ischemic stroke in 85,000 and hemorrhagic stroke in about 5,000. And then we did the same thing for myocardial infarction. That number is more like 500,000, so they're huge things, and the programs run for weeks to assess this, okay? So these are all what all this types of technology is. Now, this sort of gives you quickly what I was just saying. So you would start out with the electronic record, you read them, you have the chart review, you have a training set, and then you have an adaptive lasso technique using artificial intelligence to finally predict the phenotypes. We can do this for all the risk factors too. You can do it for smoking, for instance. We don't always ask in clinical, we don't have research algorithms in care. Did the doctor even ask if you smoked cigarettes? Well, gee whiz. And they'll say never smoker. Somebody says never smoker twice, he's probably a never smoker. But you can imagine the same thing. We can end up, and this is the future of smoking as well. You'll have a probability of whether you're a current smoker at the present time, and that could get carried forward, and it could eventually even go to you're a non-smoker. So you could be a smoker, and I'll give you a 1, let's say. So you go 1, 1, 1, no information, no information. Then 3 years later, patient says, I quit smoking a couple of years ago. So you review the chart, and so you give him a 0.3 or a 0.5, and then he says, 5 years later, he says, I've never smoked in the last 5 years. He's now a 0. So he slowly changes. And I'll tell you, that is the future of how electronic records are going to be milked, so to speak, to get what you want for risk factors, especially for those that are difficult to quantify. Well, that was what I was just telling you. It works pretty well, the sensitivity and specificity of these algorithms. And it's been done for everything now. We've done it for heart failure, for MI, for ischemic stroke, on and on. We also have the advantage of the National Death Index, which can confirm for some things. But if you have, one of the problems for those of you not used to using NDI is, what do you do for somebody who's had, let's say, major cancer? And then think about this twice for those of you who might fill out a death certificate. If a guy's had cancer and he's been under chemotherapy and then he dies, and he saw the hematologist in the last year or two, do you write heart attack as the cause of death on his death certificate, or do you write lung cancer? This is a challenge. And many of us would say you probably need to write both, going forward, and you handle things with even more advanced techniques. Okay. So this was the first major publication we had for prediction of disease using traditional factors. And we started out with the same factors that are used in the pooled cohort equations, but the numbers are big, as you can see here. This is the largest African-American population in the United States and actually probably in the world for cardiovascular disease risk assessment. For instance, the Jackson Heart Study, part of atherosclerosis risk in communities, has 4,000 people and has 500 events. So that would be the line 2, the column 2 there, men Black. We had 10,000 events and 260,000 at risk, and our baseline's 2002. I mean, they can't touch these numbers. You know, we actually have about close to 100 times as much data as they have. So, and pretty good estimators, as you can see there. Now, where we don't have as much data for sure, women are a lot less likely to become veterans. So we have small numbers, especially for Black women in our population. Now, these are the variables. When we compare, we do not necessarily just buy into using existing equations. So the science here is to compare our risk equations to what are the pooled cohort equations, which have pretty much the same variables as the original Framingham risk equations from the around 1998 at 2001 era. And as you read through, it's pretty much the same. We do not get the same issues for all of the variables, though. Smoking, we do not have the detailed information that are in the National Heart, Lung, and Blood Institute cohorts. For cholesterol, we tend to get U-shaped relationships for many of our variables. Cholesterol is one of them. So we develop and adapt new models that can take care of cholesterol strata. And then there's one variable, as you can see down there at the bottom, nobody else had ever done because they didn't have enough data, is statin therapy. So statins are not as big a winner on a population basis, and partly because we're tracking one-time use at a baseline and then whether it had an impact in this analysis. There are others that have gone beyond this, but it's favorable. On the other hand, blood pressure treatment and all of these formulations, blood pressure treatment is unfavorable, partly because we're probably treating patients for hypertension too late in the game. So it's in fact an identifier for increased risk. So, and so what should we do in the VA? Why do you do this? Well, we probably shouldn't use the pooled cohort equations in the VA. We've got our own data. So we're developing handhold models that can go on smartphones and things like this. So the pooled cohort equations are just do not fall on the line. The point is we should use our own and have those sorts of models. And in general, the pooled cohort equations overestimate about twice. So. Now, we've done this separately for diabetics. This is probably the future, in addition to Arshad and colleagues, and many of you, and for instance, at Emory here are working on advanced techniques for risk assessment. But here we've got hemoglobin A1C, estimated glomerular filtration rate, and those are both important, and they especially become players for those with diabetes and or those with the kidney function, for those with advanced kidney disease, with a chronic kidney disease. So now the problem is for some of an EGFR coming from serum creatinine is available in virtually everybody every year. It's surprising we don't have it yet in our pooled cohort equations, but it's just not there. A hemoglobin A1C doesn't tend to get done very much. I fought to get that assay done in Framingham, and for many years I couldn't get my colleagues to do it. I got it done for nothing. I begged David Nathan at Mass General to do it, and he did it for nothing. So we had several thousand, but we don't have the amount of data that you have here for all the diabetics. It's part of care for diabetics is to have at least one A1C in the chart every year that the person's a known diabetic. So, and they help refine the estimates. We've also, now with Jacob Joseph, our colleague who is at the Brigham and is now chief of cardiology at Brown and at the Providence VA, we made an estimator equation for HFpEF and HFrEF, as you can see here. The usual suspects, blood pressure, especially coming in, and there's a slightly different complex, so to speak, of the variables to predict HFpEF versus HFrEF. This is because we have echoes. And this because all the echo data was extracted, the ejection fraction was extracted, not all of it yet, because there are hundreds of thousands of echoes, and all the heart failure patients are going to get a confirmatory echo, and the EF was extracted, but we're working on getting further information as this goes forward. But as you can see here, the number of cases is huge. It doesn't have the number at risk, but it's down at the bottom there. There's over 110,000 cases, and the population is hundreds of thousands, and really over 1 million for sure. Now, this is a more recent one. This was analysis came out, Ariella Orkaby is a geriatrician in Boston and a VA investigator. Was interested in what about statins in the elderly? And if you're not aware of it, the NIH has several programs saying we shouldn't be handing out or prescribing statins to older patients because they just, it's a waste of money. In fact, that's not true. So in this paper, as you can see, everything favors statin continuation. And this was using an advanced method, which is what I call a holdout method. So if you have enough data to do this, you take baseline data, and then you go a year and you say, I'm going to take people, none of them are on statins, none of them. Then I'm going to identify the statin users at year 1. And then I'm going to follow everybody forward for 5, 10 years, whatever you want. So you are not getting people who at your baseline were on statins. I'm only now getting statin starters. You get it? Well, that is an example of a method that wasn't in place 5 years ago. And not everybody can do this, but if you have lots of data, you miss out on the first year of follow-up because, everybody was off statins as you started that investigation. But this showed that the statin initiation, they really did better. And they did better according to any of the subgroups that we actually picked. So, all right, couple of things. This came up. I was not going to have this as a slide, but I was on a call over the past 5 days with Arshad and our colleague Jan Sun in the School of Public Health, and we're very interested in obesity. So does obesity, where does it fit in for cardiovascular disease outcomes? It's not in the risk equations, but for persons who've already had a heart attack, for survivorship, it does count, as was shown in REACH analyses back in 2012, the paper that I wrote, largely with a total international cohort. But here, as you can see, we have almost 100,000 men who have experienced an MI. And how do we do this? This is another example of big data. We thought about this a long time. We're missing people who are having those MIs at age 45 who had it at a non-VA facility. But we have so much data. So how do we do this? It ended up, we picked perhaps a restrictive cohort, but we said, we'll just limit our analyses to persons, the veterans, who had their MI in a VA facility. And so we have that hospitalization. We know exactly, and then we're going to track them for mortality. All right, that was the first simple analysis. And we have National Death Index and CMS and the health record from the VA. So we really know their mortality experience. So we have 100,000 of them. And as you can see, 31,000 died. And this was 5 years of follow-up. Average age for almost all of our cohorts is really 60 to 70, or that's the range where most of the patients are, with a high degree of precision, as you can see there with a C statistic. And then these are the variables. And these are whoops, I got to go back. Whoops. So these are the variables that Jan and Arshad and I were talking about. And just focus on the body mass index there. That's the index of obesity for the veterans, 1.40, 1.0, 0.74, 0.72. Well, wait a minute. Did you say that right? That means the people who are the heavier veterans did better. Yeah, Yeah, that's right. The numbers are right. It's been triple checked. And that's what everybody's finding for survivorship post-MI, pretty much. And that's what people are finding also for heart failure. It's not so much true for initial events, but it is true for once you have heart disease. To be underweight is actually not good. And to be overweight, and this has been called the obesity paradox. It doesn't stand to reason. And that is a nut to crack. We do not understand that. And traditional factors are not explaining it right now. Perhaps our newer science, newer genetics and things, newer metabolomics will help to increase our understanding of this. Big ticket items there, post-MI. What's the biggest ticket? Easy. Heart failure. If you have an MI, have heart failure, you're in serious trouble, as you can see. Look at the racial differences. Black versus white. You know, in the VA, we have pretty much the same care for white and black veterans. It's the 7%. It's the blacks have a higher risk for mortality, but it's not huge. It's because we have pretty much the same care in all of our clinics. So the other thing down the bottom is beta blockers and hypertension. You know, so many of you are in this room, and those on Zoom calls actually are not old enough to have been part of the experience of what we call the post-MI beta blocker trials. And can you name a beta blocker that does not have a favorable effect after a heart attack? Because the prescription says everybody post-MI, and the answer is probably no. Virtually everyone saves lives post-MI. So we did both beta blocker and hypertension therapy. And as you can see, they're all on the favorable side of the equation. Yeah. Yeah, diabetes is not that big a deal in the VA after an MI. It is a stronger risk factor for sure for initial events, yeah. But that part of it may be that model in there includes body mass index. So body mass index may be pushing the diabetes out. So yeah, we need to do simpler models to address that question as well, and maybe pull body mass index out and just look at diabetes itself. So yeah, well, very fair, very fair. Yeah, and or if you're obese and you have diabetes, what is more important is all this other stuff. Yeah, yeah, it's not simple. You're exactly right. I agree. So now, how am I doing for time? So I have about 15 or 20 minutes. We're going to whistle stop through. This is mostly genetics, the rest of this talk. And then we're going to finish with genetics. So we'll make sure we get to the end. We'll have genetics and traditional factors. But I'm just going to give you a flavor. So Million Veteran Program, MVP, it's actually after multiple risk factor intervention trial, Mr. Fit. It's one of the best acronyms we have out there. So veterans like to, we can tell him he's a million veteran. He's the most valuable player in our game, so to speak. There's always a lag, 970,000 recruited, and we have the blood, but not all have had the genotyping yet. Some of them are also getting methylation genotyping. Some of them are getting whole genome sequencing. Some of them are getting exome sequencing. But everybody's getting a GWAS, and that'll be by about this time next year. We like to think we'll have 1 million. And I've given you a flavor for the breakdown, mostly men in their 60s, but it's 72% white, but large fraction of black. So by the time we reach 1 million with 200,000 Black veteran participants, it's the largest Black genetics cohort in the world. So I show some pictures, and my colleague Jan Sun, who is the geneticist, says, Peter, you often just show these pictures because they're pretty. And I said, yeah. and people like Arshad and I have trouble keeping up with the geneticists who show these pictures. But these are ethnicity and race. So we ask everybody who is in the study, you know, the white, Black, Hispanic questions and others, you know, what I call the US Census questions. But we also did genetics, and we can assign their genetic score, okay? Right? right? So the geneticists quickly nod because they've seen these before. But I want to show you this. This is my more favorite slide, is to take those sorts of slides and then you break it down into the three major groups of interest. So if all of your genes came from Great Britain, all of those people would be entirely pink, everything. So the Great Britain is in pink. But when somebody says, let's say I've got a veteran and he's Hispanic American, but well, he's probably, depending upon where he came from, you know, some of them have a lot of, as you see to the far right, a lot of Great Britain genes. And then if you went over to the far left, some of them have very little, you know, Western European genes, and they are especially have South American, and then they'll have even African genes. They're coming from Kenya. Okay, so you start to say, gee, so you can assign race based on self-reported race, but you can also do genetic race. And genetic race doesn't necessarily have to be, you know, a 0 and then a 1-1. You know, you say you're like, I am Great Britain and I don't know what I have. Haven't been genotyped. But let's say I don't have much in the way of Hispanic genes or African genes. So I'd be a 1-0-0. But as you can see there, many of the people, like you go right down the middle there, halfway across for a Hispanic. Well, that person would be about 50% Great Britain, and he'd be about 40% Lima, Peru, and then he might have some African genes as well. So this is and then this is just America. If you start going, where are the Chinese? Where are the South Asians? Well, we don't have that many. You know, so for instance, you know, you say, don't you have enough recruitment from Honolulu and veterans in Hawaii? And the answer is no. Or from Southern California, the answer is no. So these types of approaches are going to be you're going to start to see this all over the world, all these different genetic assignments. And as you can see here, the African Americans, now most of the African Americans self-report, as you can see there are two major groups. These were isolates of smaller areas in Africa, so those genes had not been, you know, they historically did not out-migrate, and there wasn't a lot of in-migration when they started to create these genetic reference groups. But as you can see, most of us are most of African Americans in the United States who are veterans, it's West Africa. And so it's like I was at a meeting and I said, the Africans are really interested in these data, as you can guess. There's a whole research consortium in Africa to study genes and especially blood pressure. And one of the big groups is in Kenya. And of course, we're having issues for how to effectively collaborate with them, but that'll be happening in the future. In the same way, we're going to get this for South Asians, East Asians, for especially for blood pressure genes. That's going to be a big ticket for there. All right, here's another big data issue. Okay, so you now have lipids. You now had 330,000 people 5 years ago, and you want to test genetics of LDL cholesterol in the VA. And so you have 330,000 people, and you probably have about 10 million measures, 10 to 20 million measures of lipids. They're not fasting. So I say LDL, but they're not fasting. Which measure are you going to take? Should you take the top 5? Should you take the average, or should you take all those which is hard to program, those when they're not on medicine? We didn't have data access, so we undertook this analysis, and we did it after a year of discussion. And what do you think we did for LDL? Can you think of anything that increases LDL? I can't think of anything. Nothing that increases LDL. So we said, how about just taking the highest LDL in the chart? The highest one for each individual. And that's what we did. So what this is a plot of the maximum versus the LDL at MVP recruitment, like what I was telling you at the beginning. It's a real look at that. You know, so we did better. We certainly, you get a different answer when you take the one at recruitment. Of course, some of those were on medicine versus you go back in time and you take the maximum. And we sent that paper. Derek Claren was the first author at the Broad Institute. He's now at Stanford. And boy, we had discussions, and this was a consortium with Emory, Harvard, Boston University, Penn, and Stanford. And a lot of expertise on this call. And of course, the reviewers said, well, why did you pick the top? We want you to do some other phenotypes. And they mentioned some of those others. And guess what? That single measure, it was the strongest association for the genetics of high LDL cholesterol. So now you always worry about outliers and things like that. But in the same way, do you think, where else are we doing this? Blood pressure. Those data have not been totally analyzed yet. Those have just now been developed for exome and then whole genome sequencing for some of those. And because somebody who has a blood pressure of 200 over 130, gee whiz, that's a different person, you know? And so we've identified those with a database in collaboration with the Vanderbilt leadership, and those data are about to be released and analyzed, because that will require more than GWAS. It'll especially get into exome and whole genome sequencing, or WGS. So, all right. I'm going to go through these real quickly. I'm just going to show a few examples because I'm going to run out of time. This is one of my favorite slides. This is from our colleague here at Emory. This is Jan Sun's paper on 10 to 15 commonly associated FH, familial hypercholesterolemia, gene markers in the American population, mostly biased towards whites. That's where the research has been. And so look at the one I like especially is the one to the far left. So the far left there, these are box and whisker plots that people who take epidemiology and biostat do these, and you plot them on and the frequencies. But as you can see, the average for that gene marker is around about 150 milligrams per deciliter. Now, some of them clearly have super high LDLs, and the threshold for adults is 190 milligrams per deciliter. So we typically say if you have the phenotype of an LDL cholesterol greater than 190, you probably have familial hypercholesterolemia. And it really goes up more if you have physical findings and or you have positive family history. But as you can see here, most of these patients have normal lipids, right? Normal lipids. And then look, on the other hand, everybody would like to think, as you go from the third from the right, you step back, you see that box where almost everybody's above the 190 line. You like to think those are the genes for familial hypercholesterolemia. Yes, that's another one of the gene markers. And that fits what your preconceived notion was almost all those people are really going to have a high LDL. But in fact, that's not the case. And what's going on here? What's going on? Well, maybe they have another gene that's doing something that is sort of taking back that adverse effect, you know, for the individuals with that gene marker to the far left. These are potentially gene-gene interactions or major. Let's say many of these people, they would only get into trouble if they ate a high Western diet, so to speak. If they were eating a lot of American vegetable diets and things, they won't get into trouble. So these gene environment and gene-gene interactions are still ripe for further research. This is just one pass at this. So these types of analyses are done for extremes of LDL cholesterol, extremes of triglycerides, et cetera, very low HDL cholesterol. And we already know many of the genes, but this is now testing on a population basis of what's going on. I'll show you one other thing here. Now, so this is a plot of the genes in the whites versus the effect of the genes in Hispanics and in blacks. So there's very little FH gene research up till now in black populations. So if you did white versus white, they would fall right on the line, okay? Right on the line. So you see the Hispanics are fairly close, But then you see the genes for the blacks are actually very different. There's a lot of scatter there, as opposed to you would expect it to be on the line. And that's because when somebody like me talks about FH genes, and we're largely premising most of what we're saying for FH genes in white populations, and mostly Europe and in North America, where a lot of the research has been led. We need a lot more research on FH in African populations, and as well, and other groups where we don't have any data here, Asian populations, where we just don't have enough data to talk about. Okay, I'm going to skip by some of these. Oh, this is a PheWAS. For those of you who haven't seen a PheWAS, so GWAS is genome-wide association studies. PheWAS is phenome-wide association studies. This is in Jan's paper. So the biggest hits at 10 to the minus 10th, these are really high statistical significance, because you have to account for the 750,000 SNPs that were on the chip. So significant up on the top left there for lipids, and then lower, but still significant above the red line for cardiovascular outcomes. And that's what we would expect. But interestingly, these genes, they really don't get into anything else. It's lipids and cardiovascular disease. They're not causing kidney disease. They're not causing lung disease. And that's what all these tests are across. And that's using the PheWAS, which is what's in that patient's problem list as part of medical care. So I'm going to skip by that. I want to show you one other thing here. So this is a collaboration which was led by Vanderbilt colleagues, Todd Edwards and his colleagues, testing really, now they're probably the leaders in the world right now. They found over 1,000 genes associated with blood pressure, but these were some of the top hits. And the point is, depending upon systolic, diastolic, or pulse pressure, you're going to get a different answer for the phenotype. So these were new findings associated with, I guess some of these slides, you can't read all of it because of all the stuff up at the top. You can't read the title, I apologize. And this is just a list of all of the different collaborations. I mentioned Derek Clarence, but blood pressure, PAD, Scott Damrauer. Scott Damrauer gave a talk here last fall, about 6 months ago, and you can get that online for PAD, cardiology grand rounds, diabetes, coronary disease at Cath, non-alcoholic fatty liver disease, Mariana Vukovic at Penn, obesity, it just came out, height just came out, height's associated with atrial fibrillation, even other things we were really unexpected. A collaboration, I'll quickly show you some findings with that with gigastroke, HFpEF and HFrEF. I didn't show you the genetics findings, but that, and then aortic stenosis. And the big finding there, we keep finding it, everybody's finding, is Lp(a). Yes, Lp(a), the lipid marker, is associated with aortic stenosis at a genetic level. So potentially down the line, we may see molecules that lower Lp(a) will be tested for whether they could reduce or prevent progression of aortic stenosis. So I'm going to skip by that. This is an example of a collaboration with gigastroke. And I know you can't read all these because of some of the black markings occurring across, but this is the study. And this is an example, Stephanie DeBette, who did a genetics fellowship in Framingham and is now back in Bordeaux, has led the world. She's got everybody in the world collaborating. She's got 2 million cases, and then she split the study. It started out being called megastroke, and then it became gigastroke. I don't know what she's going to call it after the next iteration, but it is, and the findings are only around 100 markers, genetic markers for stroke. So where's the untapped gold, so to speak, or I guess oil? It's untapped oil. Where is the oil there? Well, it's got to be upstream. It's probably blood pressure. Yeah, there are 1,000 genes that are associated with blood pressure, and those have not been thoroughly investigated for whether they cause stroke. And the answer is probably yes, but that analysis has not been undertaken yet. We're trying to get our colleagues at Vanderbilt to get going on that. This is the HFpEF, HFrEF, very discouraging. Jacob Joseph, as you can see on the bottom there, these are, when you see a Manhattan plot, everything's going up, and then a reflection plot. It's called the Hudson plot, because if you're on the other side of the river, remember, it goes down. So the Hudson plot, the only thing for HFpEF, as you can see, is FTO, which is a major gene for obesity. Same sort of thing. This is for Aaron Small, who is a cardiology fellow at the Brigham and is working at the Broad in Boston with LP(a) and other markers. He's got about 20 markers. He's doing polygenic risk scores for aortic stenosis. And I'm going to skip by. All right, so this is where I got a few more minutes. So here, so this is where we are now, is predicting heart disease with traditional factors and with genetic factors. So these are the traditional factors, and the usual suspects ring loud and clear. They are highly associated, and very much like the pooled cohort equations. And then we can investigate different outcomes: hard CVD, CVD death, stroke, MI. Now, this is one of the plots to leave up there for a minute. So which would you rather have? A traditional risk score, okay, which is on the right, or a polygenic risk score, which is on the left? Well, you say, I know for sure I don't want to be in that red line on the right. Okay, so who are those people? Those are people with traditional risk score high. They're in the top 20%. So they're the 80th to 100th percentile for our cohort. So they are in the top 20% using not the pooled cohort equations, using our own VA equations, but using pooled cohort variables. And as you chart across there with up to 6 years of follow-up, and we don't need 10 years of follow-up because we have huge numbers at risk, they have a 12% risk. So you could go even further. This is very similar to what Amit Kara had done. He's mostly focused on the red line to the left, which is less impressive. The point is the gradient for the traditional factors is much stronger, no matter where you pick, the top 20%, the middle, or the bottom. The gradients are stronger generally for the traditional factors, except for, you can see there at the bottom, if you don't have any risk factors, you're not going to get heart disease, and that's the very lowest line here in the right-hand panel. Now, where did it make a difference? And this is where I'm going to end. It made a difference for subgroups. So this is a group of individuals with a high risk, greater than 10%, is highlighted in the gray at the top of the figure. And you say, all right, well, some of these, well, the women who are in blue, it really helped out. So those were the Hispanic women, but it didn't really seem to matter so much for the men or for the other women. And then for also the women in blue who are over 55, and then in general, a little bit for the younger. So this is incidence. So most genetic studies have been focusing on prevalence, but now studies can do incidence. And we have 10 years of up to 10 years of follow-up in MVP. We have 6,000 events. It's going to get much more robust as we go forward, because we're going to have 15,000, 20,000 events with almost 1 million at risk in the near future. So this is the final slide. And this is what it takes to get into big data. It takes big groups. And you actually just talk about clusters of investigators. So as you can see here, there are a lot of people here. One of the fellows has joined. I don't have everybody. Jeff Wang and two fellows, and Zakaria are now collaborating with us in either the CVD merit or in MVP. The Boston VA, a very long list. Harvard and the Broad Institute is that middle column. Palo Alto, Stanford, Vanderbilt, University of Pennsylvania, and then isolated groups, individuals, Peter Reven in Phoenix, Durham and Duke, Denver VA, Dr. DeBet in Bordeaux, and George Thanassilos at McGill. So it's even multinational. So thanks very much.
The preceding program is copyrighted by Emory University.